This is Neurology Recall, a collection of our most useful, practical, and educational podcasts on a wide variety of topics selected from our neurology podcast collection. Whether you are new to neurology in training or have been practicing for many years, Neurology Recall is designed to help you continue to learn the essentials of neurology, easily, one podcast at a time.
Hi, podcast listeners. It's Jeff Ratliff, Deputy Editor of the podcast, here to introduce you to the Neurology Recall lineup for April 2024. April is Functional Neurologic Disorder Awareness Month. As such, we've compiled 4 fantastic conversations on the topic of FND. Regular listeners may recall the series of FND roundtable discussions hosted by Dr. Jon Stone and colleagues back in August and September of 2023. We'll kick off this episode of the Recall with those 3 discussions. All these episodes featured a conversation between Jon Stone, Selma Aybek, David Perez, and Sarah Lidstone. The first discussion originally aired on August 3rd, 2023, and covered the diagnosis of FND and new phenotypes. The second roundtable discussion aired on August 28th, and our discussants talked about how and why does FND occur. The third and final installment discussed issues related to sharing an FND diagnosis and how to engage patients in treatment. Following those conversations, we'll close out this month's recall with a conversation that Halley Alexander had with Genna Waldman on the January 22nd, 2024 episode of the podcast about reviewing psychogenic non-epileptic events and the indications for discontinuing medications. We hope you'll feel better able to manage your patients with the breadth of functional neurologic disorders after listening to these valuable conversations. Enjoy this April 2024 episode of the Neurology Recall, and we'll see you in May.
This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Welcome to the Neurology podcast. My name's Jon Stone. I'm a neurologist in Edinburgh, and I've been doing research and clinical work in FND for the last 25 years. And I'm really excited that we are bringing a whole series for you on FND. It's our FND roundtable. I've got 3 international colleagues with me, all very experienced in the field. So I'm going to let them introduce themselves.
My name is Sarah Lidstone. I'm a movement disorders neurologist practicing in Toronto and also the director of a rehabilitation program called the Integrated Movement Disorders Program that treats FND patients.
Hi, everyone. I'm David Perez. I'm an associate professor of neurology and psychiatry at the Massachusetts General Hospital, Harvard Medical School.
Hello, everyone. I'm Selma Aybek. I'm full professor of neurology in Fribourg University, Switzerland, and I'm leading a clinical program and a research program centered on FND.
So in this first podcast of 3, we're going to be talking about an approach to the assessment and diagnosis of FND and something that we've learned about new phenotypes along the way. If we can start off, Selma, with you, what do we actually mean when we use the term FND?
When we use the term FND, we refer to a medical condition where a patient presents with neurological symptoms that can be very varied, like weakness and abnormal movement, such as tremor, seizure-like episodes. And these symptoms are linked to a dysfunction of the brain. So in that sense, it is a central nervous system disorder. And what I like to explain to my patient is that the problem is not in their nerves or muscles or spinal cord, but it really lies in the brain. And the brain is unable to either integrate all the information from a particular body part or to control that body part. Now, another very important thing when we refer to FND is to stress out that it is a positive diagnosis and that we have clinical bad signs to make the diagnosis. And I'm saying that it is important because me and a lot of neurologists of the older generation have been taught that it was a diagnosis of exclusion. But since at least 10 years now, we really see it as a positive diagnosis. And it's important that neurologists and younger generations of neurologists know how to make this diagnosis.
David, take us through a bit the history here, and because there have been rapid changes, haven't there, over the last decade or two? And if you haven't been paying close attention, you might be surprised with where we've got to.
I agree, John. It's been a remarkable few decades in the field. think maybe to contextualize it, what's really happened in the field of FND is that this is no longer a diagnosis of exclusion, not something that we frame as medically unexplained symptoms, but rather using our neurologic and neuropsychiatric skill set, we can make a positive diagnosis, just as Selma pointed out, using rule-in signs on examination. And what we mean by that is leveraging our neurologic examination skill set, including observation, appreciating potential semiological features and motor patterns that might be specific for functional seizures or functional movement disorders, for example. And we also bring in available adjunctive testing, most commonly used in the workup for functional seizures, where some patients undergo a video EEG, for example. Let me give a few specific details on some of these rule-in signs. For example, in the realm of functional seizures, we can look for asynchronous movements, herky-jerky, stopping and starting, the kind of patterns that we might not see and we don't see in an epileptic seizure with major motor features. We might find that some of the seizures occur with tight eye closure at seizure onset. For other patients, for example, they may have a functional tremor. And on examination, we can direct them to perform paced volitional movements in another body part, such as finger tapping. And we can actually influence the rhythm of their functional tremor, having it increase in frequency and slow down in frequency based on those paced volitional movements. We call this tremor entrainment. These are the kinds of rule-in signs we should look for, and these are the kinds of signs we should clearly document in our examination and report.
So it's quite a change, isn't it? Because people still think about doing an EEG and saying, well, there's no epilepsy, so you've got non-epileptic attacks. But I mean, what you're saying here is that functional seizures have their own specific clinical features. Yes, we want to see if the patient's got epilepsy as well, but that's a secondary question.
I completely agree. The other piece there, too, is understanding that the video EEG allows us for really careful viewing of the seizure onset, its full duration, and its termination. And some of that adds value as well. Certainly other ways to get that data in various clinical settings.
Yeah, like smartphones, for example, particularly helpful in my practice.
Absolutely.
Sarah, I wonder if we can bring you in now. We're going to have a whole podcast about treatment. I wonder if you can just talk us through a bit how this different approach to diagnosis of inclusion influences your practice and the way that you communicate and subsequently treat your patients.
All of us who see patients with FND on a daily basis and treat them recognize that it's not enough for the neurologist to simply have this actually quite impressive arsenal or repertoire of these different positive sign examination maneuvers that they can do and then keep all that information to themselves. What's really crucial is sharing those with the patient and their family to really illustrate what FND actually is. And so demonstrating to the patient their own positive signs is, in my practice, at least in my experience, the most powerful way to really have the patient see and understand what this is, right? All of a sudden, their voluntary movement is disrupted. Their leg becomes weak. They're not able to move it. But then if we are able to hip flex on the contralateral side, so I'm in essence demonstrating a Hoover sign, for example, the strength can return to normal in extension of that leg. And when the patient sees that and looks down, they're like, oh my gosh, I didn't even realize that was possible. And the family can often have the same reaction. And so there, all of a sudden, something clicks where the patient understands that you have seen the deficit that they are dealing with every day that's really affecting their quality of life and their functional capacity. And then they also understand, wait a minute, now there's the potential for reversibility here, and there could be some recovery that can happen. And so showing patients positive signs is one of the things I do in my clinic on an absolutely daily basis. And I find it really is the most powerful communication tool in explaining what FND is, but then also setting the stage for further therapy.
Well, I'm just repeatedly struck by what a light bulb moment you can give patients with these things. And it's central, isn't it, to this diagnosis of inclusion. The other thing that allows you to do, of course, is look for FND in people who have other neurological conditions like MS or Parkinson's. Sometimes those patients do have comorbid FND, which you couldn't possibly diagnose without a diagnosis of inclusion.
I would add, too, it's not just the examination. There's a number of positive signs on the history. So features that rule in that FND is a possible role in the presentation. So an abrupt onset, for example, waxing and waning over time, although that's not specific to FND, it might increase your pretest probability. So there's many different hints that unless you ask for them, you're not going to actually find them. And it's the same thing with the physical examination. Unless you actually do these maneuvers and think about FND as you're approaching the consultation, it actually could be missed.
Yeah, I think showing people their signs has to come at the end of an assessment, doesn't it, in which you've won that patient's trust. You've maybe asked them what they think is wrong and what they were hoping for from the assessment and the experiences they've had with other doctors. And we'll come on to other symptoms as well a bit later, and psychiatric comorbidity, because we don't want to ignore that. We don't want to suggest it's an entirely neurological domain. In terms of the assessment, it's a disorder at the interface between neurology, psychiatry, many other specialties.
So we've talked a little bit about functional seizures, we've talked about functional weakness, we've mentioned functional movement disorders, but we know now there are other types of what's being increasingly recognized as functional disorders as well that have emerged in the last 5 to 10 years. And John, did you want to tell us a little bit about some of those?
Yeah, I think this is an interesting area, a sort of grey zone in a way of, are these disorders FND or not? I think they're definitely functional disorders, but I'm thinking particularly here about when dizziness is a functional disorder and when cognition is a functional disorder. And if you haven't read or heard much about triple PD, persistent postural perceptual dizziness, I think that is a really valuable category. In fact, I saw a patient today who had that, spent several years getting a diagnosis. It doesn't have positive signs in the same way as a Hoover sign, but it has diagnostic criteria that are in ICD. It describes someone with relentless dizziness, typically when they're standing, they're in a busy place, turning their head. And typically the patient comes to the clinic saying that this dizziness is just driving them mad and it won't leave them. It's often triggered by a vestibular dizzy experience, but it could be another dizzy experience. The patient today I had actually had a panic attack with dissociation. It's actually remarkably satisfying to diagnose and treat with some of the physiotherapy and psychological therapy techniques we'll be talking about in episode 3. So I wanted to highlight that. And also just to challenge the audience a bit to think about cognition as a functional disorder, because again, increasingly researchers in the field are recognizing that there probably are features of a cognitive presentation which are a bit like cognitive Hoover signs. So for example, someone comes to clinic on their own, is able to tell you about lots of times that they forgot something, can answer questions with 2 stems. Someone who may perform very badly in neuropsychological testing in a way that might be inconsistent with their performance in real life. For example, they might be working as a business person, but scoring very badly. So have a look around for research on that, because I think it's an evolving field. We still need to develop a bit more confidence about exactly how we diagnose that, but I think there's a consensus that it definitely exists. And a bit like people in epilepsy clinics being told that they don't have epilepsy, I think we've been in the habit of perhaps people in memory clinics being told they don't have dementia, but not really being told what they do have. And this is one diagnostic possibility. We've talked a bit about the main principles of positive diagnosis, but there's a lot more to FND than just the one neurological symptom and the sign. How, in the time that we've got, do we assess and help people who also typically have many other symptoms like pain, fatigue, and other psychiatric comorbidity? How do we square that circle?
John, if I may, I'd like to come back to just one additional comment around diagnosis, which is really just a cautionary note. We want to, as neurologists, make sure that we are appreciating robustly present rule-in signs, not marginally present signs where you're wondering to yourself, was there potentially a positive Hoover sign? Or was there potentially an element of tremor entrainment? I think in some of those instances, it's really important to keep an open mind and hit the pause button. And then we've also had colleagues such as Selma really highlight the importance of multiple positive signs in a given patient, again, to also increase our diagnostic accuracy. And I think that for the field, as we really put an excellent spotlight on FND, and as we then transition to some of the co-occurring symptoms, I think it's also really important to highlight that we diagnose this with high specificity and keep an open mind when there are some question marks.
We can add to that when we refer to FND, we're talking really about the presenting symptom that is neurological. But as you mentioned, John, very often these patients, actually, their burden is centered on comorbid pain. Very often they also have chronic pain. And it's very important in the first consultation to also address that, because they might not be bothered by the tremor. The tremor was the reason they were sent to the neurologist in the first place, but sometimes it's really the pain. And then it will influence greatly the treatment. And it's also useful, I think, in the consultation to ask for other problems they can have. They can describe cognitive fog. You mentioned that sometimes it's the main symptom in cognitive function disorder, but sometimes accompanying a weakness, they also have this difficulty focusing, concentrating, and fatigue and sleep disorders. So this belongs to the spectrum of FND.
And what should we do you think, Selma, if we're faced with a patient whose main problem is pain, for example, and fatigue, and they have a little bit of a functional tremor, do you think we should diagnose FND in that situation?
I think it's still useful to diagnose FND so that the symptom itself is really getting the proper label, because we could then risk that they still will continue finding or searching for an answer of why do they have the tremor or why do they have this weakness. So I think we can do both diagnosis and say it's FND and then address in the treatment plan this comorbidity.
Yeah, I think FND is reasonable, isn't it? But I must say, sometimes I would say to somebody, you've got a chronic pain syndrome and you've also got a functional tremor, but let's not overburden you with diagnostic labels, is one approach.
I think the other piece there, John, is that if the rule-in sign doesn't speak to their chief complaint, for example, fatigue or pain, I think that each of those symptoms needs a workup in and of itself. So that way, when we're speaking about our diagnostic impressions, the rule-in signs motorically may help make the diagnosis of a functional motor disorder. And certainly, a subset of patients have concurrent pain and fatigue that is part of the same condition. But I am oftentimes cautious to make that conclusion up front. I think it's important to be thoughtful in the workup as well.
And what you've said there really applies to comorbid psychiatric comorbidity as well, doesn't it, David? I mean, if someone's got crippling anxiety, we mustn't be shy to point that out and try and formulate that with the other problems that they have.
I completely agree, including the importance of a team-based approach. I know that Sarah Lidstone works in an interdisciplinary program. How do you all approach the psychiatric comorbidity piece here?
I think that's also evolved. And as medicine becomes less and less siloed and more integrated, which obviously happens varying degrees in different places in the world and different institutions, I think at least my perspective really has shifted to that of not one particular symptom needs to be dominant, right? So what I mean by that is which is actually what we did, born out of our experience in our clinic, if you have in a single room the patient together with a psychiatrist and a neurologist and a physiotherapist, each person is going to look at that patient's presentation within their own scope of training and practice and prioritize certain aspects of their presentation, but it'll likely be quite different from each other. And so who are we to say that they have a functional tremor and that's all, right? They have a syndrome. They have a syndrome of a collection of multiple different symptoms that are occurring together. And that's almost always the case, right? It's extremely unusual, at least in my experience, with functional movement disorders, or FMD, to have an isolated motor symptom without an accompanying either pain, fatigue, cognitive symptom, or a somatic anxiety or health preoccupation, for example, is super common in our most recent case series. And so who's to say that one is more important than the other? And so I think this does bring up an interesting question about framing. So if the tremor occurs exclusively in the context of panic attack, for example, or really severe anxiety, could that also not be framed as tremor as part of anxiety and not necessarily functional tremor? So I think a little bit it has to do with thinking about what treatment would be most helpful for this particular patient in this circumstance and framing the diagnosis perhaps to link up to that in a way that I don't think is traditionally followed in regular medicine.
Great. Well, I think that conversations really will lead us nicely into our subsequent two podcasts, where we're going to be talking about what we think causes FND, both in terms of mechanisms in the body and why it happens. And we're going to have another podcast about treatment. So I hope you can join us for our other 2 podcasts. It's been such a pleasure to have my 3 guests with me: Sarah Lidstone from Toronto, Selma Aybek from Freiburg in Switzerland, and David Perez from Massachusetts General in Boston. Thank you to all of you, and I hope you've enjoyed the podcast. Welcome to the second podcast in our series on FND. And in this podcast, we're wanting to explore how and why does FND occur? And those are actually separate questions, which I think, from my perspective, has been one of the problems with the field. Selma, you've done some of the best work here in terms of trying to understand what's going on in FND. Take us through a bit of how and why, and what have we learned from functional neuroimaging, neurophysiology, you name it.
Yes, John, we have learned a lot from neuroimaging and neurophysiology in FND around the past 20 to 30 years. It all started with, I think, the first SPECT and PET imaging that were able to show actually that the brain of patients suffering from FND had a completely different oxygen consumption than actors that were reproducing similar symptoms, like a leg weakness, for example. And then a series of other neuroimaging experiments have shown, mostly with MRI, that certain brain circuits have a dysfunction. And in terms of understanding how do the symptoms arise in the brain, I think one very important circuit is the circuit of the sense of agency. This is the sense that we are the agent of our own actions. And it's been shown that in FND patients, there is a dysfunction of these networks, and in particular, certain hubs, like the right temporoparietal junction, for example. And I'm citing that because it might one day lead to treatment. For example, there has been few experiments trying to target this area with brain stimulation, with transcranial magnetic stimulation. So we now understand a little bit that those circuits are dysfunctioning, and this could explain also what we observe clinically. We see that patients are unable to move one part of the body, and they genuinely report they cannot. Why do we also see that sometimes they can have spontaneous movement, like in the Hoover sign described earlier in the other podcast? We could see these discordances, and this is explained by this dysfunction in the sense of agency network. And now, John, I may continue with the why. Why does FND happen? So we don't have all the answers, but we have some clues also from neurophysiology and neuroimaging that the limbic system, so the brain areas that are responsible for our emotion regulation, are dysfunctioning. It's been shown that the amygdala, for example, has a hyperactivity, and that's the connectivity between these areas, the amygdala and the motor system, in particular the supplementary motor area, for example, are abnormal in FND. So it doesn't explain all of it, but we see a link clearly between emotions and psychosocial factors and motor loops that could be linked to the symptoms.
I think one of the really exciting things for me is the way that we can layer these explanations on top of each other. So I think people, for most of the 20th century, had this very sort of unitary view that FND was a psychological problem, psychogenic. The Freudian view was they're all converting stress into neurological symptoms. And in many ways, I think the reason that lasted so long was just such a simple idea. It's easy to sort of get your head around. But I think what we've got now in the field is an approach to this question of why involves trying to understand this multiple levels, from the neuron to the network to the person to society, really. And for me, that's a much more exciting, multidimensional way of looking at cause.
Yeah, I fully agree also that we can really explain also to our patients that this dualism, it's either the brain or the mind, is actually not a good model, that our emotions are also dealt by these areas, the amygdala I mentioned, and that they are linked to their symptoms. So sometimes it really helps also in the conversation with the patient to link together those psychosocial and motor symptoms.
Selma and John, such great points. I oftentimes like to highlight that the brain doesn't separate into neurologic circuits and psychiatric circuits. In fact, some of the higher order integrated multimodal circuits that cut across neurologic disease and psychiatric disease are precisely the circuits that are implicated in the pathophysiology of functional neurological disorder. The other piece, too, is with FND, we use the term functional. And I think it's a wonderful term. And yet increasingly we know that structure and function are closely coupled in the brain. And in fact, a number of brain areas that have shown functional alterations, both in task-based fMRI as well as in connectivity analyses, also show structural alterations at the microscopic level. So it's really an issue of scale. We can think about the macro scale, large lesions, as really being in many ways the domain of neurology. But at the micro scale, it's really about both structure and function nonetheless. And frankly, maybe we should obliterate this sort of false distinction, as was previously mentioned, and really think about complex brain disease, period, across a range of domains that have been nicely highlighted here.
I think you're absolutely right, David. It's a tough one, though, isn't it? Trying to undo 300 years of Cartesian dualism in the 5 minutes that we have to deal with these things in clinic. But I think that shouldn't stop us from thinking big when it comes to the field and how we move forward with this disorder.
Well said, John.
But just thinking back to these sort of multiple layers perspectives on etiology, I think it's really important to say when we're talking about the brain, that doesn't mean that we don't want to think about the person, what's going on in their life. Although we had this model of stress being the cause of FND, it is definitely the case that there is a relationship between recent stress in some people and FND symptoms. There's very few conditions where stress doesn't make things worse, is one thing I might say to patients. But it does seem to be particularly relevant to some people with FND. But I think it's a bit like thinking about smoking and heart disease. So smoking is relevant to lots of people with heart disease, but not everyone. And if someone tells you that they are not a smoker, they've still had a heart attack. And it's not that they're lying about being a smoker. It's just that it's a multifactorial model. If you look back to adverse experiences in childhood, they are about 3 or 4 times more common in people with FND. So I think we need to have a model here that doesn't discard these important psychiatric risk factors, psychological risk factors, and we do so in a way that doesn't stigmatize them with patients. And yet we can still talk about the brain as well.
Yes, John, I really like the way you frame it in the terms of risk factors, because it has been viewed for a long time as causal, and patients get that message sometimes also when they go online and then they go on the web and they see this psychogenicity. So it's really important in the conversation with the patient to stress out that those stressors are important in being risk factors. And in fact, going back to neuroimaging, there are also now recent studies that showed that some brain areas have a different volumes, being the gray matter volumes, or we recently also found that the volume of the amygdala and the hippocampus are smaller in these patients. And it might be related to some childhood trauma. And the current model we understand is that there might be some gene environment interaction, in the sense that there might be a set of genes that put people at risk of developing FND. And then if they have childhood trauma and then maybe later in life also adverse life events, that may play a role in triggering the symptoms. But we need a lot more research in this area. So for now, I think considering those as risk factors is very important.
The other thing I wanted to bring in here was we talked about stress and how that might be important. But in terms of events that we come across in our patients, what I was struck by starting this research 20 years ago was how commonly physical events seem to be a very important trigger. Of course, physical events like injuries and illnesses are also psychological events. But that's something that, again, was known about perhaps 100 years ago, but kind of got forgotten about. Sarah, do you want to just talk us through a bit about the importance of finding out about physical events that people have had, particularly when it comes to functional movement disorders?
Yeah, and I can even tie in a little bit of the earlier really fascinating discussion. I think spend a lot of time in our clinic because the focus is on trying to build together with the patient a symptom narrative, we call it, because many patients come and very rightly don't understand why they have FND. No one's told them. And it can be a really complicated question to answer. And I find I don't really have a leg to stand on unless I spend a lot of time trying to understand their evolution of their symptoms over time. As we talked about in the first podcast, seldom is there only a single symptom. Very often, at least in data in our clinic, for example, non-motor symptoms predate the onset of a motor functional symptom by at least 6 to 7 years. And that's common in other publications as well, and also common in other movement disorders, including Parkinson's disease, for example. So there's hints that there's things that are going awry in the nervous system many, many years before. And so I'm frequently kind of digging back into people's childhoods, actually asking around questions, for example, were you often in the emergency room as a child, and often were you sick and people couldn't explain why, or history of accidents or things like that, physical injuries as well. And I agree with you, John. What is surprising is there are these histories of these types of encounters, either with the healthcare system or bodily symptoms or adverse events or neglect that are in the history that are there. And there can be this weaving that you can kind of pull out through the story over time. And then very often there is another precipitating event. So I had a lady, for example, who had a jellyfish sting her leg, and then she developed a functional weakness in that leg 4 to 6 weeks later. And so we very commonly see an injury as a precipitant of a movement problem. And I think that there's hints in there, as Selma was saying with the imaging studies, that brain is vulnerable. The brain is vulnerable to developing FND in that individual for a number of different reasons, whether they be genetic, whether they be epigenetic, whether they be environmental, and the interaction of all of those, likely social, that render this brain vulnerable to the onset of FND that can happen later in life. And that's usually, in terms of the studies, around midlife, around 40s and 50s in some individuals.
Including, I think it's really important to understand that there isn't a one-size-fits-all in FND. And it's important to underscore, at least in my opinion, and I imagine everyone on this panel, that FND is etiologically and mechanistically heterogeneous. A number of us are thinking about subtypes, and subtyping neurologic conditions is far from new in research. And so there are a number of conditions this is happening in, and most certainly it should be work that we do in this population, including that the subtyping may or may not map on to the external phenotype. And these are some of the questions that I think over the next few decades, hopefully we'll be able to answer.
David, when Sarah was talking about physical injuries and the jellyfish stinging someone's leg, I think we've become increasingly aware about other types of comorbidity of bodily disorder, neurodevelopmental disorder, which might help us explain why some people get FND. There's been some really interesting research on these comorbidities. I wonder if you could just tell us a bit about that.
We can think of FND as a disorder of communication across a range of brain networks. And I like to highlight, frankly, I think even in the age of AI, our fanciest computer in the world remains the human brain, in my opinion. And what we're learning is that themes, for example, such as a history of joint hypermobility may be a risk factor for developing FND. This has been shown in functional movement disorders as well as in functional seizures. And we can think about this from the perspective of predictive processing. So our brain, to a large degree, predicts before it experiences. We issue predictions about the sensory consequences of our movements based on past experiences and based on a range of concepts that we've organized and refined through time. When we issue predictions, we then look to see if a prediction matches with incoming sensory information. A lot of the great work highlighted in this podcast today has really talked about top-down, higher-order neuromechanisms that might be implicated in the pathophysiology of FND. But when we think about joint hypermobility, may there also be disruptions in bottom-up information that ultimately is contributing to how the system is being scrambled? And I wonder about some of this literature in joint hypermobility and related areas being an important consideration in the future as well.
I think it's been a real lesson for me, this, because I think probably now that I'm asking, it is pretty clear that it is more common than it should be in the population, although it is common in the population as well. Perhaps up to 20% of people have joint hypermobility. I think we need to be open to new ideas about comorbidity and perhaps challenge our existing views on causation. So I hope we've given you a taster, at least, of some of the ideas floating around in respect to the how and why of FND. I think this is a problem that I will spend the rest of my life grappling with, and I will probably never get to the bottom of it, but we've certainly made a lot of progress. So in podcast 1, we talked about diagnosis. In this one, we've talked about the how and why. I hope you can join us for our last podcast, where we'll be talking about sharing a diagnosis of FND with patient and subsequent multidisciplinary treatment. Many thanks, everyone. Welcome to this third FND roundtable. This episode, I'm really pleased that we're going to be talking about communicating, sharing a diagnosis, and treatment. This is the thing that many neurologists feel most uncertain about. Sarah, you're running a multidisciplinary service for people with functional movement disorder. Do you want to give us just a very brief overview of how you think about treatment for FND?
Yeah, absolutely. I think the first message for our listeners out there is that FND is absolutely treatable. And what's really, I think, the most important thing is that the treatment is not one size fits all. So it's not like the rest of neurology where we're so accustomed to you make this diagnosis and then the patient automatically, quote unquote, receives treatment X, Y, or Z. It's a little bit different when it comes to FND. There is a big emphasis placed on education and a big emphasis placed on moving towards self-management and being able to engage in treatment, whether that looks like physiotherapy or different types of psychological therapies. And so this is how the treatment for FND differs from the traditional medical model that we're very accustomed to using as neurologists. And so at the most basic step, the first step of treatment, in my view, is a good diagnosis and education. So resources that explain what FND is, that are reliable. Neurosymptoms.org is a great resource for that, and there's many others that are popping up all of the time. And then subsequent to that, really depending on what the patient's top concerns are, right? We already discussed in our first and second podcast in the series that FND can often be a syndrome with many different symptoms. And so what I find is a very helpful step is to really ask the patient, what is it that you struggle with the most? What are your top 3 symptoms, for example? And what are the things that are really getting in the way of you living the life that you want to be living in terms of your symptoms? And then aligning subsequent treatment with whatever those are. Okay, so just because me as the physician might think that the tremor is the most important symptom to treat, if it's not aligning with what the patient actually experiences in their life, that's probably not going to be very helpful and it's probably not going to be very effective. And so options for treatment are physiotherapy. There's now a really good evidence base around the use of motor retraining physiotherapy in functional motor disorders. Psychological therapies, there's a list of those that includes things like cognitive behavioral therapy and other types of psychotherapies that are longer term. And then also multidisciplinary team-based therapies, either as inpatients or outpatients. And so there's a whole host of options that are available now for patients, although in general, these are fewer and far between and under-resourced. So many neurologists talk about how patients with FND can be challenging to treat, challenging to diagnose. And there has to be some type of emphasis placed on improving both patients' experience, but also the neurologist experience. And John, do you have any thoughts about how that dynamic can be tackled and improved in any way?
It's such an interesting area because when I think back to talks I would have given 15 years ago, I was probably telling people, try this, try that, that'll make it easier. And increasingly, I think I've got one major piece of advice for people trying to share a diagnosis with patients with FND is just don't be weird. What often happens is the neurologist behaves weirdly. Instead of saying to the patient what they have wrong with them and why they've made the diagnosis, what kind of treatment might help, they say things like, oh, your scan is normal. Or they might start jumping to a discussion about stress or some potential etiological factor before they've even told the patient what they have. So I think my top bit of advice here is just do what you normally do for every other condition. How do you tell someone they've got migraine or Parkinson's disease? You have to start with, you've got migraine, you've got Parkinson's disease. Why do I think you've got Parkinson's disease? Because you've got a resting tremor and bradykinesia. Why do I think you've got FND? Because you've got typical features with a positive Hoover sign or an attack where you fall down, lie still for 3 minutes with your eyes closed. And as we talked about in episode 1. So I've come to the conclusion I don't need to give any specific advice about giving a diagnosis of FND. You should label it the way you're comfortable with, but please just do what you normally do and don't do something weird would be my top recommendation.
Can I be provocative and ask you, John, where you think that discomfort and weirdness comes from?
I think it's a feeling of that many doctors have that FND is something other. We have words like non-organic and organic, where we've lumped together all of the organic things. And then for some strange reason, we believe that there is a non-organic part of the human body which could give rise to symptoms, which if you think about it, doesn't make any sense. It's been othered. I think instead, if we just think of it like a category of human illness, like vascular conditions, inflammation, cancer, it's just a lot easier. So I think people haven't necessarily been made to feel that it's just a normal category that they can treat in any other way. And so they approach the consultation in an awkward way, and then the patient picks up on that, and it often goes badly.
I might also really highlight the importance of our educational backgrounds and trajectories. One of the things that I'm really struck by is that George Engel, a medical internist, published in Science in the late 1970s, the notion of a biopsychosocial formulation, really highlighting that a treatment approach that had a singular focus on biomedicine and pathophysiology in a number of clinical contexts would fall flat or fail to deliver precision medicine. This notion of patient-centered care. When we talked about this in an earlier session, but one of the challenges with FND treatment, as was highlighted, is that what we use for diagnosis, when used in isolation, sometimes doesn't translate very well to a patient-centered treatment plan. And that's where I also think that this field of FND is such a great field for both the general neurologist as well as subspecialty physicians such as movement disorder physicians or epileptologists, as well as a number of physicians across the aisle and clinicians in general that really are interested in this intersection of brain and mind and body. Neurology meets psychiatry meets physical rehabilitation. I think it's just so critically important. And frankly, it's this bit of uncharted territory, in my opinion, that makes this work so impactful and exciting. There are many gaps, though, and I think we're talking about some of those gaps together.
I think we can argue FND is a subspecialty of neurology, and one where it should really attract neurologists who love clinical neurology, taking a history, doing a physical examination, and then using communication skills to really try and help patients. And when it goes well, it can go spectacularly well. I was going to bring you in, Selma, here, just to tell us a bit more about what comes after that when you're giving someone a diagnosis of FND and where you take that.
That is so true that some neurologists feel that these patients are difficult or it's a difficult consultation. I think one of the factors could be that they feel some helplessness. They might be able to make the diagnosis, explain the diagnosis, but what then? Some of the neurologists don't have access to specialized clinic like we have in this panel or like the multidisciplinary center that Sarah is leading. But there are still many things that neurologists can do, and our listeners should be empowered to also reach out to specialists around them. For example, when I have a patient that cannot come to our specialized clinic, I will try to diffuse the information. There are, for example, now a consensus recommendation for physio. So I would make a photocopy of these and give them to the patient so that they can bring that to their physio. And I would make my team available for a phone call to exchange on how is the treatment. So there are other ways also to diffuse the therapy. Same thing with speech therapy, with occupational therapy. So we can do it, of course, in a university clinic or in a specialized center, but there are also a lot of materials that can be used by other specialists. And I think this is very important as a message that neurologists are not alone. They can work in team, even if they don't have access to an FND clinic.
John, can you just tell our listeners a little bit more about the consensus recommendations for physical therapy, occupational therapy, and speech and language, all published in the JNNP?
All of those had lead authors that were relevant therapists. It was very interesting with the physio ones. That was the first one because we got together in a room a group of neurophysiotherapists who'd been treating these patients. And we said, what are you doing that works? And even though they didn't really know each other that well, they were all doing quite similar things. Intuitively, they'd realized that what they were trying to do was promote these automatic movements in FND that were usually quite well preserved, and try and retrain the brain, help unlearn unhelpful patterned voluntary movements that form the basis for the FND. And we've seen something similar for our occupational therapy and speech and language therapy recommendations. I say they are recommendations, not guidelines, but they've certainly helped the field move on. And I agree with Selma that quite often it is helpful just to share those with therapists who perhaps don't know about FND, explain some of the principles, become familiar yourself with a few of the ideas in there, just to communicate that this is not necessarily rocket science. It's just a slightly different way of doing what they normally do.
It's very useful, and there's a lot of bedside therapeutic techniques that, as Selma was saying, you can actually do with a patient in their office. So, perfect example where John was just talking about this automatic movements are preserved, and that is also a positive sign. So, if the patient, for example, is able to take off their shoes and off their socks, for example, to examine them, and those movements are normal, and then during the examination they develop a tremor in both of their hands and they're not able to hold anything, you point out to them the positive sign that there's internal inconsistency. So they're able to, on the one hand, on the automatic movement of tying their shoes and taking them on and off, the hands worked fine. And then when I go to examine you, now that your brain's paying attention to the exam, the tremor is going to be coming out. And so really the homework, or the exercise, if you will, is for the next 2 weeks when you're at home, try to notice all of the times that your movement is temporarily normal, even if it's just for a few moments or a few seconds. Even that exercise biases the brain to now, instead of looking for dysfunction, to look for good mobility patterns. And a shift begins to happen where the person is now able to notice that their movement actually can be quite good from time to time. And that's actually the beginning of rehabilitation. And that's not through a physiotherapist or a psychological therapist of any kind. That's just from the neurologist giving the patient a suggestion at the bedside.
Yeah, I agree, Sarah. And I think sometimes if someone comes into your clinic thinking they've got MS and they go out thinking they've got some kind of software problem of their brain they've never heard of, but they sound reasonably hopeful about, that's a massive change in cognition. It's not cognitive therapy, but it is a huge shift in cognition that is essential for that rehabilitation. Perhaps most of our listeners are working in a situation where they don't feel that they necessarily have someone to refer a patient to with this diagnosis. What would you say to a neurologist diagnosing functional seizures who doesn't have a specialized sort of FND psychotherapist to send them to? Is there anything the neurologist can do in the short time they have that's going to be helpful?
The first 2 points might be the emphasis on education, on validating the patient's experience, and hopefully there's some comfort on the neurologist side to explore some of the social and mental health components to get a sense, is this part of the active clinical picture or not? Ultimately, we need to team build, and team building is not an easy thing. It doesn't happen very quickly. What I will say on the psychotherapy side, for functional seizures, also known as dissociative seizures, we have a fair bit of robust evidence for cognitive behavioral therapy. We need to think as neurologists, well, what is cognitive behavioral therapy? How is it going to help this patient recover from their functional seizures? In cognitive behavioral therapy, we're exploring relationships between the patient's functional neurologic symptoms, including but not limited to their functional seizures, thoughts, behaviors, emotions, and life factors. Now, with functional seizures, there's a couple of really key components to the psychotherapy approach. And that includes training the patient in relaxation and distraction techniques, exploring with them, might there be warning signs for their events? There's, for example, the phenomena of panic without panic, this notion that there's heart racing and shortness of breath and nausea preceding individuals who go on to then have a functional seizure. As awareness of warning signs and triggers improves, might there be early patient engagement in use of those relaxation techniques and distraction techniques targeted towards the warning signs to prevent events? And really this notion of patients coming back into the clinic using cognitive behavioral therapy in consultation with a psychotherapist, and really reporting back to the neurologist, finding ways to prevent myself from having a seizure. That's really, really powerful. There are a number of workbooks published in the field that can really help catalyze how to build teams and how to have neurologists also educate their psychotherapy and psychiatry colleagues on what's available. It's this crosstalk One doesn't have to know all the aspects of psychotherapy to engage in that crosstalk, but being an interested neurologist who says, let me chat with my psychotherapy colleagues about this patient population, and let's see if we might be able to build a pathway together. This can be really wonderful.
I think it's about encouraging people that even in 5 or 10 minutes, that the neurologist who's made the diagnosis is in such a good position. If it's gone well, they're in such a good position to help that patient just move a little bit further. Not necessarily giving all the treatment, but just describing roughly what it might consist of, which for some patients, they can really pick up that ball and run with it, I find.
So important, John, including having the neurologist remain involved longitudinally, right? So that maybe they're helping to coordinate to get the patient connected to other services, but then let's schedule follow-up and let's walk this therapeutic journey together. I think that's really, really important. And I think as a neurologist, it's important to walk that therapeutic journey with our patients.
Certainly one of my bugbears, I suppose, is about follow-up, because I think if most of us diagnose someone with multiple sclerosis, we would arrange to see them again. You've told someone they've got multiple sclerosis or Parkinson's. You see the patient again because you want to know how they're feeling, what do they think of the diagnosis. We've got this weird habit in our specialty of not seeing people with FND, which means that you're not really sure how your explanation communication went down. One of the things you'll discover, by the way, is that if you just give people a website for FND and say goodbye, that is not enough. And I say that as someone who made a website for patients. I think information helps, but that follow-up can be a crucial appointment to actually find out, does the patient agree with you? Is it the right time for them to have therapy? In my experience, it isn't always the right time. Sometimes it's best to wait, or sometimes the patient just isn't looking for therapy at that moment. They just want some peace of mind about what's wrong.
I think that's also a really important point as well, is that the patient's not always going to agree with you. And that's okay, right? Your job as a neurologist is to do a really good, thorough evaluation, diagnose FND and any other comorbidities that might be present based on your good, careful history examination and investigations if necessary, and provide a diagnosis as empathetically as possible with good resources and education. And if with all of these boxes being checked, the patient doesn't agree with the diagnosis, wants more opinions, then I think that's okay. The patient doesn't have to agree with you. And it's not your job to have to convince anybody that they have a specific diagnosis. And I think that people need to hear that message and be reassured, because as John, I fully agree, not everybody is ready for the diagnosis or even for treatment at the time of assessment. And hopefully down the road that might change in subsequent follow-up.
And for the treatment to be collaborative. I think that's so important, right? As a clinician, we can provide our opinion, but we should also allow flexibility for the patient to disagree with our opinion and to just have a transparent conversation about what might be the best path forward.
And I can jump in on that based on our experience also in an FND clinic, is that we have an inpatient program, for example, but even before considering this inpatient stay, we always make a consultation with the patient to discuss about the aims. It's very important that the patient agrees and knows what is expected and that we have common goals, that we don't have over high expectancies and then the patients are disappointed about the treatment because it doesn't go as fast as they can. And that can have also a negative consequence on the team that gives everything that they can and still the patient doesn't improve. So this is really important, as you mentioned, all of you, to have the right timing for such a treatment. So I guess it's really to have a tailored treatment plan between the treating neurologist that should, if they want and can, stay involved, and the specialized centers.
So I think what we've heard there is the importance of thinking about triaging the patient. Is it the right time for this patient to have treatment in their understanding of their condition? But what I would say is that when you treat FND, it can be a fantastically rewarding experience. When patients have been unable to walk, they can walk again, they're having lots of seizures, the seizures stop. This is as rewarding an area of clinical neurology as any, in my experience. So I do hope that our podcasts have encouraged you to feel hopeful about FND and to give hope to your patients. We made 3 podcasts, one on diagnosis, one on the how and why of FND, and this one was on treatment. It's been such a pleasure to have my three guests with me: Sarah Lidstone from Toronto, Selma Aybek from Freiburg in Switzerland, and David Perez from Massachusetts General in Boston. Thank you to all of you, and I hope you've enjoyed the podcast.
Hello, this is Halley Alexander from Wake Forest University. Today I'm bringing you some highlights from the American Epilepsy Society meeting on a topic that's very relevant for all neurologists, the topic of psychogenic non-epileptic events. And I'm here today with Genna Waldman from the University of Pennsylvania, and she gave an excellent talk on this topic at the annual meeting, so I'm really excited to share her insights with you today. Genna, thanks for joining us.
Thank you for having me.
One thing I want to discuss right off the bat, I noticed in your talk, the term we're using now is psychogenic non-epileptic events, or PNEE, but of course, sometimes we'll see psychogenic non-epileptic spells. In the past, they've been referred to as pseudo-seizures. Can you just talk a little bit about if there's a difference between those and what exactly is the best term to use now?
What's the best term for this disease is an ongoing debate. I think it's important to remember that this disease falls into the general group of functional neurological disorders in the DSM-5. But among neurologists, like you said, some people call it psychogenic non-epileptic seizures, psychogenic non-epileptic events, functional seizures, or even dissociative seizures. And going forward in this talk, I am going to be using psychogenic non-epileptic events. I find that it can be confusing for patients to use the word seizure in the disease label when then I'm going to go on to tell them that they don't have seizures and don't have epilepsy. So the name can be different when you read different references, but in general, it's all the same disease. And it's a disease where the clinical semiology has no electrographic correlate, and it's not epilepsy.
So what are some of the key things that we should remember when we're trying to deliver this diagnosis of PNEE to patients?
A theme of us talking today is certainly going to be that accurate and proper diagnosis is really key to the prognosis in this disease. And I think there's an appropriate way to approach a patient about this. PNEE, I think, is very challenging both for the patients that deal with this disorder and for practitioners. To best care for them, a multidisciplinary approach with neurologists, psychiatrists, and mental health care providers together really gives the best care. That's not always available, and it's often the neurologist that's giving the diagnosis, and we're seeing these patients a lot in our office. I think the things to remember when you're talking with your patients is to use really clear language. This is an established diagnosis. This is a real disease, but this is not epilepsy. And once you've done the proper testing, which we'll talk about, I think, in a little bit later, further testing is not required once we give the diagnosis. I think it's really important to provide guidance and education to the patients that PNEE is not volitional, and it can be just as unpredictable as epilepsy. And communicating that can help provide validation to the patients that their symptoms are real, confidence in their providers that we know what this disease is, and to help them engage in treatment in that multidisciplinary approach and give them hope that resolution of symptoms is achievable.
And now you mentioned, that giving the diagnosis, accurately and clearly can impact the prognosis. So can you talk a little bit more about that?
Exactly. Accurate diagnosis to this disease is really so key. The longer the duration of symptoms are tied with a poorer prognosis. So really an emphasis on doing proper testing and providing the patients a comprehensive diagnosis is what's going to impact their ability to have some resolution or improvement in their PNEE disease. The International League Against Epilepsy recommends video EEG monitoring as the most comprehensive evaluation to both evaluate that clinical semiology, what does it look like, and how does it differ from epilepsy syndromes, particularly that frontal lobe epilepsy syndrome, and with that EEG ictal correlate to see that there's no actual EEG changes with the event. However, if an experienced clinician sees the semiology either in the office or on video, and you have an ambulatory non-video EEG that has the event without the ictal correlate, that's also sufficient to make this diagnosis. And I think a really good point to remind our listeners and all of our physicians and practitioners who are dealing with this diagnosis is there was a nice review by Dr. Stone in the British Medical Journal that reported the misdiagnosis rate for these functional neurological disorders is quite low, around 4%. So if you feel like you have the expertise to evaluate these disorders and are familiar with the clinical semiology and how it differs with epilepsy, you should have confidence in your ability to make this diagnosis. And if there's no interictal abnormalities on that prolonged EEG monitoring, 24 to 48 hours, you really shouldn't have that much doubt that you're missing an epilepsy diagnosis. And this diagnosis is critical. Just with the diagnosis, on average, 50% of patients will have resolution of their PNEE when leaving the epilepsy monitoring unit or getting that comprehensive diagnosis in the office. And so we really need to emphasize how important and valuable the diagnosis is to these patients and to their prognosis with this disease.
Those are all really excellent points. And I think it's important to remember, especially if you're at a tertiary center where you get a lot of refractory patients, it can seem like the misdiagnosis happens more often than it does. So it's helpful to remember that it's really only 4%.
I wanted to make another point and draw attention to kind of two groups that have done a lot of work in this area around diagnosis and prognosis. Vobler's group in Germany did a prospective study following patients after the diagnosis in the EMU, and they had resolution in patients about 25%, but that was maintained even 2 years after the diagnosis. There's several other studies that look retrospectively after the diagnosis in the EMU and then following their charts. Specifically, Asadi Puya has done a lot of work in this area. And even in centers that don't have access to psychiatric care, 52% of patients can remain event-free following the diagnosis of this disease.
Now, when we're diagnosing this, I know sometimes in the back of our minds is just that concern that maybe they have psychogenic non-epileptic events and an underlying epilepsy that we, are afraid of missing. So can you talk about how common that overlap actually is?
We definitely know both diseases can occur together. About 10 to 25% of people with PNEE, psychogenic non-epileptic events, will also have epilepsy. So it's not the majority, but certainly there is a proportion of patients who have them both. In terms of those that have both, there's similar rates of drug-resistant epilepsy, so it's not a reflection then of epilepsy disease severity. There's some nice studies from Massot-Touros published last year that look back at patients who had only epilepsy and PNEE and epilepsy to see if there was some characteristics that differentiated between the two groups of patients. And it's more common if you have PNEE to have minor head trauma, migraines, anxiety, and chronic pain. And when you have both PNE and epilepsy, and so you also have that epilepsy component, it's more common in patients that have developmental delay, abnormal MRIs, and if their episodes and seizures are shorter in duration. So sometimes history, can help you have a higher suspicion of which patients you might want to continue to look for epilepsy in. But again, many patients with PNEE, most patients with PNEE will only have PNEE and not have epilepsy. And I think seeing the events on video can be very helpful, or if they happen in the office, for you to have confidence in really what the clinical semiology is that they're experiencing. and then that EEG evaluation and a prolonged one, again, up to 24 to 48 hours to screen for those interictal abnormalities that might make you then have a higher concern for a dual diagnosis, although interictal abnormalities isn't the defining feature and certainly would make it a more complicated patient if you still think the events are really epilepsy, but someone that you might want to keep a closer follow-up in your own practice to kind of review what's going on at home with the patients.
And that 24 to 48 hours of monitoring, it's helpful if you can do all of the anti-seizure medications, but although that might not be possible in some of the settings where you can only do the ambulatory.
Yeah, I think those that have access to an epilepsy monitoring unit can really be helpful because then I think you can take off the seizure medications at the beginning of the evaluation, which I think can help transition to discharging them off medications and discontinuing medications. Induction techniques like photic stimulation and hyperventilation, even when patients know they're being used to try to induce events, have been shown to be helpful at seeing the events. And independent of the frequency that their events are happening outside the hospital, it's quite common to see non-epileptic events occur within the first 2 days of the recording. So it wouldn't be expected that they would need a prolonged EMU stay, but I think it can be very helpful if you have access to the epilepsy monitoring unit to really help get that documented, clinically established, unequivocal diagnosis of PNE.
And then we touched on it a little bit, but the reason we've spent so much time talking about the accuracy of diagnosis is just because it can be helpful, like you mentioned, to discontinue anti-seizure medications in these patients if they don't have epilepsy. So can you talk a little bit about the risks and benefits of discontinuing anti-seizure medications once you've diagnosed PNEE?
Yeah, I think this is what it all comes down to, right? Is should we be exposing and continuing to prescribe seizure medications to these patients? And when patients start having their events, over 75% will end up being on a seizure medication at some time. And the longer it takes for them to get their diagnosis, likely the more seizure medications they've been exposed to. And unfortunately, even after the diagnosis is made, up to 40% of patients will remain on medications. So I think this is why it's really important to review this topic and to talk about it, because we know that isn't what is now medically recommended based on what we know about this disease. PNEE is not epilepsy. Seizure medications are not indicated. And exposing patients to seizure medications unnecessarily can lead to medication side effects and can lead to mismanagement in the emergency room setting when the diagnosis isn't clearly differentiated from epilepsy. In studies that's looked at this and followed patients, whether they continued medications or discontinued medications at the EMU discharge or at follow-up, there were higher rates of remission in those who discontinue medications at the time of diagnosis compared to follow-up. And there are higher rates of complete resolution of events if they're able to leave the epilepsy monitoring unit off anti-seizure medications completely. And this has been studied in some retrospective studies, and then one nice, albeit small, randomized controlled trial by Otto's group that was published in the Epilepsia Journal. Resolution of events is not paired with high or low frequency. So even if patients are coming in with really high frequency of events, it can still and should be the plan to have them discontinue medications, and it is safe for them to leave the epilepsy monitoring unit off medications. Also, in patients with that dual diagnosis, if you're able to differentiate between the events, and if patients are able to understand and differentiate themselves, then if medications had been increased for what then is diagnosed as PNEE events, it's also been found that you can safely minimize and decrease seizure medications when you're focusing them around those PNEE events. So practitioners shouldn't feel like they have to keep medications at high doses or multiple medications if when looking back, it was clear that those medications were increased or added for PNEE events in those with a dual diagnosis. I think it's important to emphasize that accurate diagnosis and discontinuing of medications that can lead to resolution of events, but then it also leads to decreased use of emergency medical services. And given that PNEE events are characterized by prolonged events, they can be misdiagnosed as status epilepticus. And so there can be real adverse effects by not approaching the management correctly and leaving patients on seizure medications inappropriately.
What else should we try to remember? What are the clinical pearls we can take when we're thinking about diagnosing and managing patients with PNEE?
Early and accurate diagnosis is key to the first step in managing these patients. And trying to decrease that delay from symptom onset to diagnosis can impact their prognosis and help resolution of events. It's important to validate patients that their symptoms are real and non-volitional, while also emphasizing that it's different than epilepsy. Seizure medications are not recommended for the treatment of this disease and should be discontinued, but it's always important to ask, is there other indications why patients are on these medications? For example, someone might be on lamotrigine for depression, Depakote for migraines, and certainly there then are instances when a medication is continued, but it should be clear that they're not for the non-epileptic events and therefore the other indication. Both those key factors, an accurate diagnosis and discontinuing of medications, can lead to resolution. And there are variable rates listed in the literature, but it's on average around 50%. So there's certainly going to be a lot of patients in your practice that the disease persists. Psychiatric care is then an important component, and there's an emphasis on cognitive behavioral therapy treatments being effective above and beyond basic therapy techniques alone. Another takeaway that I want to emphasize is that a hallmark symptom of PNEE is that there's variability and there's non-stereotyped characteristics to the events. And it can be a challenge when retesting is needed. And I think that's where a neurologist's follow-up care can be a key component to this disease. A neurologist can provide reassurance that the symptoms are still consistent with PNEE and can have the clinical acumen to know when retesting is indicated and when you have a higher clinical suspicion for that dual diagnosis. So while at some point treatment has to transition into mental health care and psychiatric care, oftentimes the question is, how and when should a neurologist still be involved? And I think that's really the key position that a neurologist can play in the follow-up care of these patients, is when you're taking your history and hearing them still have events in those patients that don't have resolution, you can provide reassurance that this is still the same disease and help them try to focus on psychiatric care and mental health care that can be valuable, and reassure them that seizure medications really can cause harm and that are still not indicated. Well, there's a lot of patients out there that I think neurologists can have a big impact on, because we really are the most well-trained to diagnose this disease and then often have the most comfort in discontinuing medications. We certainly need more research on interventions for those who the disease persists. And I'm hopeful that in the years to come, we can provide some more options to patients.
What I love about this talk and the information you've provided is just helping us keep in mind that sometimes we think we don't want to be too quick to diagnose somebody with PNEE. So we try to keep that kind of just in case, or like, well, that level of doubt because we're worried about they're going to go and have a seizure. But the information you provided has really helped highlight that keeping that level of doubt just in case can actually do a lot more harm for these patients. So it's good to do the proper workup and then be confident in your diagnosis and relay that confidence to the patient. So again, thank you so much for joining us today, Genna. And we will link some of those articles that you talked about in today's show note. Thanks again.
I know this can be a really difficult disease for all of us to deal with in our offices, but knowing you have confidence in making an accurate diagnosis and that can really impact a patient's disease trajectory is certainly something I hope you take away from today.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.